certainly to manufacturers as well. But let's go ahead and introduce the members of the Policy Roundtable who will be with us. We do have, I'll note, Dr. Michelle Kittleson and Dr. Matthew Maurer, who are with us for the morning. In addition, we have Sean Riley and Milton Mitchell, two patient experts and advocates. So with that, I'd like to introduce two new members to the roundtable, two new people for us here. And let me start with John Watkins. John, would you like to introduce yourself and your conflicts? Oops, you're on mute though, John.
Hi, I'm a pharmacist from Premera Blue Cross in Seattle. We are Blue Cross Blue Shield, Washington, and Alaska, and I have no other conflicts.
Thank you very much, John. Nice to have you back. And Alyssa Guest.
Hi, Alyssa Guest. I am a pharmacist by training, currently an Associate Director of Clinical Pharmacy with IPD Analytics. We provide insights to payers and providers, manufacturers on the competitive drug landscape. So happy to be here. I have no additional conflicts of interest to disclose.
Thank you. And I do like to point out each time you are kind enough to participate in our policy roundtables that IPD Analytics is not an insurance company or a payer in that sense. You talk to a lot of payers and you serve as a repository of information and perspectives. So it's wonderful to have someone from IPD Analytics who can speak often broadly to what is going on in the payer community. Whereas John, to a certain extent, we don't ask him to speak specifically about what Premera is doing, but he's got a lot of experience and can bring an individual company's perspective. So thank you. We can take down the slides so we can all see each other in bigger format here. Okay. And I'm glad that we still have the folks who were here earlier this morning, because I like to start where we almost always start off these policy roundtables, is to take a step back and to talk about equity very broadly conceived. And a lot of these issues came up in some of the earlier discussion around some of the votes. But I want to make sure that we turn the problems into recommendations, if you will. So for the things that we see that are problematic in bringing any new treatment, any new effective treatment for patients with ATTR-CM into practice, how can each element of the healthcare system do it better in ways that will reduce disparities in access, that will reduce disparities in outcomes across whatever kinds of groups you wish to focus on, racial, ethnic, geographic, other kinds of questions. So we heard about some of the problems this morning, but again, we want to not gloss over them. We can revisit them, but I also want you to start to think proactively and don't be shy. Imagine that you have a very powerful force behind you, and what you ask for might actually happen. And you'll get to have a final recommendation at the end of the session, but we'll start there. So I heard a lot about problems with diagnosis, right? Access to it, disparities with it. Maybe I can turn to the clinical experts to start with that one. And again, frame for us the problems as you see it, and then who needs to take specific actions to help make that better going forward? Michelle, why don't I start with you?
Sure. Absolutely. I tell clinicians there's 3 hurdles when it comes to cardiac amyloidosis, broadly speaking. Number 1 is you got to think about the diagnosis. Number 2, you have to order the right tests in the right sequence and interpret them correctly. And then 3, therapy, which is the easiest if you've gotten through the first 2 hurdles. So where do you start? And we know that diagnosis is so critical. Number 1, to make the right diagnosis, is it truly TTR? And number 2, earlier diagnosis is better, because of where we are right now. We have no therapy to reverse disease. We can only slow or halt progression. So the earlier you get your patient on therapy, the better quality of life you can preserve. So the question is, how is the way that we increase awareness so that people are ordering the right tests for their patients? Does that happen on educational programs? Honestly, the manufacturer of tafamidis does it very well with the commercials. And many of us have patients who come to us and say, I saw the commercial and I have all these things. Can you test me for amyloidosis? I suppose that's one. So education on whatever level it happens to be, clinician, patient, that is going to be absolutely critical And then the second one, which I think is so tied to that, is making sure you order the right tests, because you never want to miss a diagnosis of AL cardiomyopathy. And 10 to 20% of people with a positive technetium scan may actually have AL cardiomyopathy that is not recognized if the monoclonal protein screen is not also checked. I think that's getting better and better, because many times insurance won't pay for the tafamidis unless they see the monoclonal protein screen, but whether there can always be a knee jerk whenever that scan is clicked upon or order report is done, that the right monoclonal protein screen is always also ordered, that would be a huge step to correct diagnosis.
So Matthew, I'll let you have your say on that, but I'm kind of curious how the guidelines are currently framed and promulgated out from ACC or otherwise. Are there any patients who present with heart failure who shouldn't be screened for ATTR?
So two reasons. Well, and I think the guidelines, the 2022 heart failure guidelines did a beautiful job. I don't say that just because I'm one of the authors, but did a beautiful job saying that it's obligate to order a monoclonal protein screen whenever you have this suspicion with the technetium scan. And how does it promulgated? There's all kinds of webinars and medical educational things like that can be really helpful. And then you had a second question that was really important, and I lost the train of it.
Well, it was kind of, I mean, ultimately, as we train medical students and residents, are there patients for whom it's not appropriate?
Yes, thank you. That was
right. And I guess part of that might be linked to a follow-up question I was going to ask, which is the screening expensive? I mean, I know I might ask the payers about this, but if we did a screen for this for every single patient with heart failure in the country, is that a mistake just on a cost basis, given how little the yield might be?
100%. I'm going to deal with that question on a patient level, and then I'm going to toss it to Matt, who's part of the SCAN initiative. So let's start with, just as a physician, right? You should never check a test unless it's going to change your management, and your pre-test probability guides your post-test probability. So if your pre-test probability is low, their walls are not thick, they actually don't feel that horrible, they have clear signs of another competing diagnosis that could be causing your symptoms, please don't check the amyloid screen. The second group of patients is if it won't change your management, meaning they are so advanced in whatever disease process they happen to have, that initiation of a disease-directed therapy to slow or halt progression is not going to appreciably improve their outcomes. They have, unfortunately, terribly advanced dementia. They're bedridden from some other horrible condition. What is the point? What am I doing to this patient by trying to make this diagnosis and prescribed therapy? So those are the two on a clinician level where I would not do testing.
All right. Matthew, let me let you chime in, and I'll also ask the patient experts about what they see in their communities around diagnosis.
Yeah,
go ahead.
I think you said who should not be screened. I don't think we're probably ready in this stage for widespread screening of asymptomatic individuals. I prefer to call it active ascertainment. These are individuals who have signs and symptoms of the condition, which are unfortunately for clinicians very protean and non-specific. There are a whole host of, as Michelle was indicating, preceding orthopedic manifestations that heighten the potential for this particular phenomenon, lumbar spinal stenosis, carpal tunnel, biceps tendon rupture, and so forth. I would note about 83% of patients we ultimately diagnose have a preceding orthopedic issue that could bring it to bear. And while I'm a huge fan, as we all are, of early diagnosis, I think there's a corollary to that, and that is, as we all know, that when we start screening populations with very low pretest probabilities, we get into a circumstance where the false positive rate goes through the roof. If you're at all concerned about drug costs, you can imagine how bad that would be. This drug doesn't cause any harm. No one's going to get any side effects, but it will, really expand the budget if we end up putting people on this drug that don't meet indications for it. So, we have, as Michelle said, a screening study that was funded by the NHLBI, National Heart and Lung and Blood Institute in New York, Boston, and New Haven, in which we were trying to focus on the minority populations who are often left out and screen them. I would note that the high-level finding is that, while it's quite prevalent in certain populations, particularly in older adult males, say over the age of 75, who are Black. We're talking a prevalence of 1 in 4, 1 in 5, potentially 1 in 3 having amyloid. The biggest issue is that a genome first approach won't be useful because a majority of patients still, even if you're a minority, have age-related or non-genetic and wild-type disease. And so people could conclude if you do a genome that, oh, you don't carry the variant either ALA60 or V122I that we heard about, and you don't have disease. In reality, you still could.
Thank you. Just for context, you may not actually know what insurers pay for the full diagnostic workup. Does anybody know?
Yeah, it's not very expensive, to be frank, not comparable to what you're talking about of the drug costs. So every way we do a cost-effective analysis, it falls over not on the examination. A PYP scan is variable. You can get as low as 500 or as high as 1,500, and the serological tests are not very expensive, a few $100s. So you could screen quite a few people probably at a reasonable rate that would be cost-effective, but the drugs make that impossible.
Okay. So Milton and Sean, you guys probably think it would be great, as I do, for every patient with an amyloid heart condition to be seen by Dr. Maurer or Dr. Kittleson, experts at that level. Diagnosis happens quickly, treatments happen well, care is well coordinated, et cetera. In your work with the patient community, what do you think has to change, and who can change it to improve diagnosis? Are there other things that can happen besides the usual channels of, kind of education of clinicians and patients?
I'll let Sean go first.
Yeah. So you asked if there are other. First of all, I'm a huge advocate of educating the medical community, and it's based on my own experience. I went 6 to 7 years pre-diagnosis in an area of the country. I'm from metropolitan Boston, which
We couldn't tell by your accent. We had no idea.
yeah, I have a wicked good Boston accent. But anyways, so great healthcare, right? It's one of the centers in the country, if not in the world. And even at that, I went 6 to 7 years with my first symptoms were bilateral carpal tunnel. Then I had GI. Then I had a doctor, a cardiologist, do a scan of my heart and tell me that I had an athlete's heart. And what he was actually seeing was the thickness in my left ventricle from amyloid. It actually took me moving overseas to the United Arab Emirates. Fortunately for me, the Cleveland Clinic has a center over there. Yeah. They actually finally did an initial diagnosis with a technesium scan. So what I'm getting at is even in the best of situations, being that I lived in a place with great healthcare, it took 6 to 7 years and no one caught it. It took me having to move overseas before I by chance got diagnosed. So educating the medical community to me is paramount. And every time I talk, I speak mostly to second-year med students and also some residency programs. And without fail, it's an eye-opener to them. So as much as the education is getting out there, I do believe that it's still in its infancy.
All right. Thank you. And Milton, I'd love to hear your perspective on this.
Ditto to what Sean said. Also, I think we need to take a little bit step further and drill down to maybe even particular minority communities or sections in urban communities, maybe even like the PCP doctors, the primary care doctors, because I was diagnosed myself by my primary care doctor just on an annual visit. And that saved me a great deal, I believe, till this day. He knew a lot about it. I couldn't believe it. I was a little bit tenacious with him because I was showing him that I had none of these symptoms that he was talking about. He says, I see the outside, but I know the inside. And that calmed me down a great deal because of the total respect that he knew and had knowledge. So I believe that the primary care stage, the early stage, of some sort of diagnosis or a test or something, maybe screening or something, would be a critical help, because most people in the urban communities, I mean, you got your primary care doctor, and sometimes you tend to lean on him a little bit more so than the hospitals, the emergency room, et cetera. So I just think, you know, at the primary level, seeing your doctor or someone that, you know, is very close to you is very important. The second thing I like to say is, like Sean was speaking about, I had, what my wife had when I was married at the time, had Blue Cross Blue Shield, federal. That was a great help to me because it started out with me in Maryland. I ended up in Washington, D.C., and then I ended up in Virginia. So the coverage is a part of it as well. So I always want to include the different facets of trying to stay healthy with something that I consider to be a rare disease, even though the numbers might be small in context, but there's still a lot of people that have this, and then there's so many different variants. I have the variant 122 IE, but even within that, then you have the wild type. So there's so many different tests that has to be run. And, you know, it could be costly, but I think if you catch it early, or if you have enough tests early enough, that you can limit the long-term problem that you can have. In my case, for 2 years, I was with ICD because of the detection part of it. But maybe if there was a test being run earlier or not, that maybe been detected. So I do think early detection at, you know, baseline areas would be a very good help.
Great. So it sounds like the groups that do have, if you will, lines of communication into minority communities, be that community groups or organizations that deal with, you know, primary care clinicians and others, that there might be some real special opportunities for education there to increase their knowledge, especially among, you know, senior citizens, it sounds like. I have a question. Good. I was going to pitch it back to Matt or to Michelle anyway, but Matt, go ahead since you've raised your hands. I want to ask one or both of you about the first screening test that a primary care doctor might order or a primary cardiologist, and the differential, for instance, thickness of the heart wall with women and those kinds of other things we might want to change. But before I get there, I just wanted to say that so I didn't forget. Matt, what did you want to say?
Yeah, I just wanted to you know, comment that while I think it's great if primary care doctors know this, I think Michelle's done a fantastic job at educating, you know, probably the more frontline providers that encounter this and make a mistake, which is cardiologists or particularly heart failure doctors. The other group that you remind me of is, you know, pathologists play a very large role in certainly the diagnosis of light chain amyloid, not as much as in TTR, but these orthopedic manifestations occur very frequently, and often the orthopedist just chuck the tissue in the garbage. So if we get, you know, surgeons to actually send the tissue off, they're a little reluctant, they've told me, because they don't have the repertoire and they don't know how to manage it, but I think we can teach them. And then we need pathologists, a lot more of them, to know how to do Congo red staining and be able to do that. So there are focal points where I believe there are probably opportunities.
Okay, great. So again, since we're telling people what to do, who needs to do what to improve the diagnosis of women with ATTR-CM?
That's such an interesting question, you know, because even it's more common in men, and even the variant form is more commonly presenting in men. So there's some kind of genetic environmental interaction here. What's interesting to me, and I love Matt's perspective because he's done beautiful studies on this, is some of it is, I think, the definition of increased left ventricular wall thickness. Because in the olden days, it used to be, you know, 1.2 centimeters is LVH. And now we know that increased LV wall thickness can be variable depending on your age, depending on your sex. So I think we have to have a lower index. It doesn't have to be severe increased LV wall thickness. You need to think about it sooner. And you'd also ask, what's the first test a primary care doctor needs to do, or anyone? Well, what are the most likely presenting symptoms? Fatigue, dyspnea. So if you have a patient with dyspnea, it's typically a knee jerk at some point to get the echocardiogram. So all roads lead lead to the echocardiogram, and that increased LV wall thickness on the echo might not be super increased, might just be a little increased, might just be increased because of age and sex, not by the old standard criteria, should lead you down a path where you ask yourself, why are the walls thick? And unless you can totally convince yourself, oh, it's just their hypertension, then you really need to delve deeper and say, maybe it's not muscle, maybe it's infiltration. What else do I need to know?
All right, that's great. Okay, I'm going to be my own timekeeper, obviously. So I want to, every once in a while, it'll feel like we have more to say, but I want to kind of keep us moving forward. But the next aspect of kind of improving equity as new things come into practice, let's talk about a bit about insurance coverage. I want to get into the weeds a bit about specific coverage points. But like right now, patients trying to find, you know, a clinician who has expertise here. I think actually, Matt, you mentioned telehealth earlier, some of the other issues. Again, if we're going to try to improve things long-term here, what do we do with specialist deserts, you know, the kinds of problems that some patients might find? How do we improve access for them?
You know, we need a lot more docs to take care of these folks, or other allied health professionals. I mean, it's really, to be honest, not rocket science. Clearly, I'm doing it, but this is not the rarest of rare diseases. This is quite overwhelming, quite frankly, and patients are waiting a long time. And some of the barriers I mentioned before. So, you know, I would love to see on an advocacy realm the God willing Congress pass a dispensation to say for rare diseases which patients can't get access to because they live in a rural environment with no expert, we waive the requirements for licensure in that state in order for an expert to perform you know, consultation via telehealth. We can figure a lot of this out and give direction to a local provider in a simple way. And then I think I mentioned some other barriers to more widespread genetic testing. Ironically, this is a disease that almost exclusively affects those who are of Medicare population. Medicare doesn't cover genetic testing. So, you know, like, what are we to do? Luckily, we have sponsors of these drugs that actually do cover genetic testing for obvious reasons, but that's not the way to, I think, do this. So those are some suggestions.
My apologies, I didn't know that. So Medicare right now, CMS does not cover genetic testing for ATTR-CM. Is that right?
Correct, right.
Huh. Okay. Might have to explore why that might be the case. I don't know if it's different for commercial insurers or not.
Oh, it is. It is. Commercial insurance does cover it, but Medicare does not. You know, so I don't
Okay.
think it's TTR specific. I think it's genetic testing in general. But here's a disease that disproportionately afflicts, or almost exclusively, older adults. So that's a dilemma.
Okay. I want to move cautiously because we're going to have more to say about it later. But just in general, let's say you have diagnosed a patient and it's time to start to think about prescribing treatment. Is the prior auth process working efficiently enough to be serviceable to help obviously weed out patients who might not be appropriate for treatment, but not create tremendous barriers for those patients who are? Again, we'll get into the specifics of which elements of prior auth might need to change later, but what's the overall experience like in your experience, you two guys?
I mean, it is still complicated. Maybe when you just add the prior auth plus the need for patient assistance programs, because the costs are sometimes still quite high, there is a lot of paperwork and there are a lot of hoops to jump through. And we have one nurse in our office who's basically, that's his only job. And every October, the landslide of paperwork comes in and you have to sign 100 more things. So ultimately, I have very few patients for whom cannot take it at all because of financial reasons, but it seems to take a lot of effort to get them to that point.
Matt, your experience?
Yeah, I mean, I'd say it's a law of thirds regarding price. Just so you know, a third of patients pay nothing, a third of patients pay very little, meaning, in my opinion, $50 to $100 a month may not be a little to them, and a third of patients pay, you know, upwards of $1,000 to $2,000 per month per year, though that's gotten better with the Inflation Reduction Act. We couldn't manage our population without our specialty pharmacy. We have, 5 technicians / pharmacists who not only ensure that patients get access to the drug, but call them and deal with concerns or complaints that they have, which are totally appropriate. I would point out that an institution like mine, Deep Dark Dirty Secret, does pretty well on prescribing tafamidis to the tune of tens of millions of dollars a year in revenue, is my understanding, though they won't ever tell me what it actually is, because 340B is able to somehow purchase the compound at a lower rate from the sponsor and then distribute it. So my institution, while I think they like me, doesn't do anything that's not financially remunerable, and this is quite profitable for them.
So let me ask you a follow-up question that might change the way that your hospital views you. If they like you now, they may not afterwards. But let's think about equity. Is there a way that the spread that the hospital can accomplish between the price it buys it and it gets reimbursed for, does that trickle down to patients? Do patients at your hospital, for instance, pay much less out of pocket based on the 340B element there? Or, I mean, do you see any connection between the two?
As I said before, I mean, ironically, the people who are most impoverished pay nothing. It's just that the process is more difficult and it takes them longer. I would say 3 times as long. When we first started doing this, ATTR Act was published, it was a morass and there was no access, and it took us months to get people on drug, and there wasn't a system. Now, most people are able to start on drug within 3 to 4 weeks, I would say, sometimes 2. The patients who it takes longer are patients who are if you will, underinsured. They're in self-insured insurance that doesn't want to pay for it, and there's a lot of access issues. So there is, I think, a discordance between how much you pay and how long it takes, and they're not linked in that regard.
Okay. And Sean and Milton, I don't know specifically whether your patient advocacy work has focused very much on the insurance experience, but it probably has. So is there anything that you'd like to point out kind of as an overarching element about the way that prior authorization is being done that could be more helpful for patient access?
Defer to Sean first again.
Actually, I'm very fortunate. I have Blue Cross of Massachusetts, and so I'm in a pretty good situation insurance wise. The only thing I can really offer is, that in talking with other patients out, in the communities and the meetings that I go to, is that this is definitely, and we're already talking about it's a pretty widespread burden, particularly with people that are don't have the unfortunate enough to have the quality of insurance that I have. So I am one of the lucky ones, I guess.
Yeah, you're right, Sean. At that time, prior to me having my transplant, I had Blue Cross Blue Shield, as I stated. After that, then I had different coverage. So now I go into a different arena, which affects my health. Why? Because now I don't know going forward with the different types of visits, doctor appointments, blood work, et cetera, that I'm gonna have to have, or proper medication that I might need. My insurance might pay or might not pay. So now somebody got to think about that. So the different types of insurance that you have, whether it's state, whether it's federal, whether it's private, that makes a big difference. It makes a big difference even with your family that has to caregive for you. So that's a tremendous burden, how that is about with the insurance company. The different types of insurance that you have, it makes a huge difference.
All right, well, let's talk a little bit about some of those specifics. Part of what our policy roundtable documents put out, Matt, I'll come back to you in 1 sec. I want you to start to think ahead. We usually do comment on some of the specific elements that you'll find in a coverage policy and ask questions around how is that supported or different from the clinical trial data? How is that different or the same as the FDA label? And especially now with what will look like multiple options for treating ATTR-CM, there'll be a lot of interesting questions about how formularies manage the choice that patients and clinicians will have. So we're going there in 1 second after I'll let Matthew come back on something.
My comments maybe are in line with that. So there's a lot of heterogeneity in these drugs. Some are Part D, David, in Medicare. Some are Part B. And obviously, out-of-pocket costs are different. I would urge ICER to reach out to the Amyloid Research Consortium, arci.org, run by Isabel Usada, but they're a patient advocacy group, and they've done a tremendous amount of work on patient access, heterogeneity, variant wild-type patients, differences in coverages throughout the United States, and there's a lot to be learned.
Thank you for that recommendation for sure. Okay, John and Alyssa, your time in the limelight is coming shortly. So just again, stepping back, heart failure is always headline news inside an insurance company, right? Lots of patients, lots of costs, lots of opportunities to improve care. Frame it as you will, it's a big ticket item. And tafamidis is a big ticket drug, right? It's kind of become standard of care. It's relatively expensive, depending on, or very expensive, depending on your point of view. John, any thoughts on, again, as we start to move towards some of the specific elements of coverage, how you view the landscape with tafamidis kind of established and these two new drugs, one with a similar mechanism of action or very close to the same, and the other a different mechanism of action. How will an insurer start to parse the evidence and think through what it covers and how it covers?
Well, they're going to look at the evidence as just as we have today. And what I heard currently is I'm not seeing anything that would support putting some kind of step therapy in place. The other question is, can you add vutrisiran on top of tafamidis? And I think the panel already voted that they didn't see the evidence for that. So I'm pretty sure that's where the insurers will come down. I'm just looking at our policy for tafamidis, and it looks very much like the diagnostic criteria that we have just discussed. And I'm going to predict, I think this is one area where you'll see early application of AI to support prior auth reviews at both ends of the line, because it can submit the information from the provider. At our end, what you're probably going to see right now, we have pharmacy technicians who do the first line of review. But once you have AI in place, if it can check all the boxes to approve, then it's done. If it can't, then it goes to a pharmacist who will dig a layer deeper. And so I think that's going to be a big help. I'm not an IP person, so I don't know the timeline, but it's coming. One more thought on the desert question. We have Alaska, which has more empty space than any other place in the country. So we think a lot about that. The Blues have a system that allows relatively straightforward coverage if you need to go out of your state to get specialized care. So we've got that one covered. I don't know if you're dealing with some of the other insurers, how that would work.
Okay, thanks. I'm not sure we'll come back to AI, so I'll just state for the record that I think people are both cautiously optimistic, but also somewhat anxious about whether that will help or hurt prior auth. And as you said, there's a bit of a war going on between insurers and providers sometimes over whose AI can be more adept than the other one. And so thank you. That's a good overview. And Alyssa, so again, as you are having conversations or in other ways hearing what's going on, and people have been seeing this potential competitive landscape, for a while now with tafamidis in at least the pole position because of its earlier approval. What do you see as some of the major trends that payers will be considering as they look at coverage? And again, then we'll drill down into some of the specifics.
Yeah, so generally, I'd say two main things. We're looking at the possibility of step therapy, and we didn't really get into the specifics on pricing, but as we look for a potential approval of vutrisiran for ATTR-CM, that carries approximately $200,000 more annually in cost from a list price perspective. So that is a possibility and definitely something that there's a lot to unpack there. And then, as John had already mentioned, combination therapy. It was interesting to hear from the clinical experts today, their take on the Helios B data and where they stand on that. But I think that will definitely be an ongoing concern for payers. They're already seeing requests today for combination therapy, not very frequently, but it's there. And of course, another thing we didn't get too much into today, but is the mixed phenotype patients who have cardiomyopathy and polyneuropathy. And we're looking to potentially have the first therapy that will carry both of those indications. So there needs to be special consideration there from payers in how they approach. They can't just look at, ATTR-CM as one, but they have to consider that as well. So I think those are going to be the big things that, P&T committees are going to be discussing, and unfortunately, questions that we don't have necessarily answers to right now, but something we'll have to keep close eye on.
All right, thanks. Okay, so let's go a little bit deeper into some of the specifics. And our team takes a scan, if you will, of some of the publicly available coverage policies just to see how much variation there is in certain ways. There's always, they have to, a lot of people don't realize this, but each insurance company kind of has to do its own due diligence on the evidence and put it together, not, on a clinical basis before they even usually start to think about the finances. But you get some interesting differences. So for instance, some insurers will have just very, very simplistic coverage policies that say pretty much what the FDA label does, that, for instance, tafamidis is approved. This is Blue Cross Blue Shield of Massachusetts. Tafamidis is approved for people with ATTR-CM, and they're being treated for cardiomyopathy. Full stop. Other insurers have about a page, and this is probably where, Michelle, where your staff is involved, right? A page of things where they have to have radionuclide imaging and or an echocardiogram and or a biopsy. I'm just saying and or because it's usually and with very complicated ors written into a computer algorithm. And they have to be either class 1 or 2 or class 3, but not too sick in class 3, right? So that they're sick, but not sick, too sick, if you will, to match the patients in the trials. But most of the variations are really just that. It's kind of a level of specificity. And so just as part of one of our general recommendations, I'm curious whether you think that there are patients who could be misdiagnosed. Is there a reason that insurers should go really into the weeds with some of these very specific criteria to get it right? Is that a good thing for insurers to, in a sense, help make sure that clinicians are doing the right thing? What do you think about the pros and cons there, Michelle?
Oh, I would be delighted by that. And I think that would make the insurance companies happy because they wouldn't be dispensing a super expensive, unnecessary drug. And it would be the right thing for the patients to always ensure that the diagnosis of TTR amyloidosis requires a positive technetium pyrophosphate scan and a negative monoclonal protein screen, and
Right.
an appropriate monoclonal protein screen, IFE, not SPEP. And the second step is if the monoclonal protein screen is positive, then they obligatory must have a biopsy that shows tissue diagnosis, that subtype of TTR. I think that would be hugely important to operationalize this incredibly important step in diagnosis to save patients from getting undiagnosed AL amyloid, inappropriate use of tafamidis, and not receiving their life-saving plasma cell-directed therapies for AL amyloidosis.
All right, Matthew, I'll let you say if you have the same.
Yeah, I think the pre-certification process is cumbersome, but not inappropriate, to be honest. We published data to show that, for example, scintigraphy, when it first was utilized, relied on quote unquote planar imaging, which is an X-ray, and just seeing uptake in the area of the heart. That is inadequate because many patients can have blood pool. So in our series that we published, the false positive rate was 9.3%. So we definitely see people up to probably 10% who are misdiagnosed, don't have disease, and are getting on an unbelievably expensive therapy. I would parenthetically note, given the ads that are out there, patients are pretty uptight. They read the articles that say it's a rare, progressive, and ultimately fatal condition. And there are people who have carpal tunnel syndrome, no amyloid in their heart, but they want therapy. patients, I don't think they're wrong, who have disease do want combination therapy. And when someone was mentioning before, we're seeing a large denial rate, which probably may be appropriate at this point, given the absence of data for people on combination. We don't have a lot of them, but those people who are on combination are now being told we're not paying for it anymore,
Right.
because the costs are astronomical. And I agree with what someone said before, which is if all these therapies come out the same price, then we may have some egalitarianism. But if they come out different prices, I'm very sure that as an insurer, you're going to tier therapy given the absence of unequivocal data that shows one is better than another. I would say that the neuropathy market is very small. The cardiomyopathy market is 50-fold larger, so you would expect the price to come down.
Yeah. So that's, just to be clear, I heard you correctly. You think that every patient before they are potentially started on tafamidis or vutrisiran, they should have a cardiac biopsy?
No, only if their monoclonal protein screen is positive.
Only if, okay. Just wanted to make 100% sure, because the old
100%.
standard was to do biopsy.
No,
now.
no.
And that happens in under 15% of patients
Yeah.
nowadays.
Okay.
We can diagnose 85% of people without a biopsy.
But the point is they have to have the monoclonal protein screen. That's the
Got it. Okay. Okay. That's great. All right. And when it comes to the delivery route later, so let's talk about we're going to talk about add-on or combination therapy, and then we'll talk about step therapy, which it's hard to kind of separate them in a way, but
Sorry, can I just make one more point, which I think, so all these therapies, as Michelle said, are preventative. And so what we saw originally, which is a real problem, is if you have a heightened awareness, now you're seeing someone who had an orthopedic procedure, they found some amyloid, they get a PYP scan, it's demonstrably positive, right? They clearly have the disease, but they don't have necessarily an elevated NT-proBNP or not in the range that was included in the trials. Those patients in the past and sometimes now are being denied therapy. That doesn't make any sense to me as a clinician, because you're just waiting for someone to progress to a state in which they're worse. And then, to be honest, they don't regain anything after they've progressed. And so there's a side where I think, insurers are kind of on the wrong side of the coin, denying people who have manifest disease access to treatment. And that's probably going to grow as we get earlier and earlier diagnosis.
Okay, thank you. I did note that. That's going to be very helpful for us. Okay, so let's talk about the challenging for everybody question of combination therapy. I can just note that the ICER report itself rated the evidence of the incremental or added benefit of adding vutrisiran to background tafamidis as an A, and the panel voted that the majority voted that it did not have, that there was not adequate evidence to demonstrate an added benefit of vutrisiran as an add-on. Insurers are listening, and you already heard a little bit, they were listening very carefully to that part. I mean, everybody is, because that's going to be a huge question clinically, but also financially. I don't think it was mentioned in the meeting today, but at least my quick scan was that the price for vutrisiran is about the list price at least is $576,000 a year. So if we think of adding that on to background tafamidis, if you want to think of it that way, and we'll talk about sequencing it later, but that's a huge question. So Alyssa or John, I mean, the first thing that happens in a P&T committee is they do say, what does the clinical evidence suggest about an added benefit here? Is it a real thing that we need to cover? And then we'll deal with the finances after that. I'm not sure if you've taken your own deep dive into this question, or if just maybe in Alyssa's case had others talk about it, but where do you think insurers are going to start on that question?
I can start, John. I think every P&T committee, how it starts is taking a look at the data. They have pharmacists who analyze the data, just as the committee did today. Prior to the HELIOS-B trial, the data was pretty scarce. I think even, the guidelines previously recognized that that data was very limited. Now we have more. So it really will come down likely to each P&T committee and their assessment of that data and how compelling they think it is. It does present some challenges in interpretation to those who don't, live and breathe data all day long. So I do think we'll see some variability because it's not clear. It's not like this overwhelming benefit or this overwhelming lack of benefit. So I think it's likely we'll see some variance there. But, you know, I think as we all discussed today, there's reasons to believe that there's additive benefit and reasons to not be fully convinced yet. So it's a hard question to answer.
Thank you. That's a good answer. And John, let me make it even a little bit harder for you, maybe. Let's say that an insurer declines to cover combination therapy in general, but a clinician seeks an exception. Their patient who's been on tafamidis has just moved from New York Heart Association Class 2 to early Class 3. They really want to add vutrisiran because the patient looks like they're progressing. Do you think the insurer is going to say no, full stop? Will they say you can go on vutrisiran, but you have to stop tafamidis? I mean, how do you think that's going to work out?
Yeah, I unfortunately have not seen the study that we're referring to, only the summary of it from this morning. My understanding is the study was not primarily designed to answer this question, which automatically bumps the level of evidence down one to me. I would not have given it an A based on that alone. I would want to see more. I think most P&T committees in payer world will. On November 19th, I get the lovely job of presenting the content of this meeting in about 10 minutes. So I may have a question or two for your reviewers when I get to that, but I don't have enough information to answer. But in terms of how we approach things like this in general, there is an old principle that goes back at least to Roman jurisprudence that whoever proposes something has the burden of proof of providing evidence. I don't have to prove that it's not true. You have to prove that it is.
All right. So Matthew, put on your Roman kilt or whatever it is and describe how the clinician perspective, and I know you guys did comment upon this yourselves during the meeting, but it might be helpful for you to refresh our memory of your view of this question. And then also how you think the broader cardiology community may take it in terms of their potential variation.
I'm personally very conflicted. I mean, I adore my patients. I think biologically there could be an option in which you lower the protein by 80%, 85% with a silencer, but there are still a few buggers hanging around, and combination therapy could be useful. We've been using combination therapy for years in people with mixed phenotypes in which the stabilizer is diflunisal, which actually Jeff Kelly, who invented tafamidis, discovered. It's an NSAID at 250 milligrams twice a day. And someone who doesn't have significant cardiac involvement is quite well tolerated. I think Sean said he might be on it as well. So that's a cheap way to get people on both, but a lot of patients with advanced heart disease can't tolerate it. So being an advocate for patients, I understand where they're coming from. And this is one of the more difficult conversations I often have to have. I'm having it right now in a woman who's got Val30 met. She's a mixed phenotype. I put her on tafamidis initially, and then she got on vutrisiran, plerixafor, and now her insurer is basically saying there's no evidence, and I've given her the advice that a silencer in her case is better than a stabilizer, but she's not content or happy. I would point out that it's going to take a much larger number of patients, as I said before, with lower event rates. There is a trial that is fully enrolled with a silencer. It's called CardioTransform. I'm the PI, and it has 1,443 patients with TTR cardiac amyloid, of which probably 70% of which will be on tafamidis. So we will have a much larger N to determine if combination therapy is efficacious. To be honest, I still think the price should drop tremendously on all these therapies, and then this discussion wouldn't be very difficult. If it was cheaper, no one would really be balking that much, which is where the problem lies, in my opinion.
We are coming to that 800-pound gorilla for sure. We're coming at it fast. Michelle, any other thoughts from your perspective on this combination therapy issue?
So to tag on what Matt said, let's pretend cost isn't an option. Let's pretend they're all free. Would I still want to give my patient both? Really, the pathophysiology troubles me, because if I silence something 80%, do I really need to stabilize what's left? I just don't have an answer to that question that satisfies me from a pathophysiological perspective. And then when I look at Helios B, I do not think it convincingly tells me that there is a benefit of combination therapy. I think that monotherapy, I believe it. I believe that vutrisiran has an effect. I'm just not convinced they showed me that there's they didn't show me there's an additive effect with the combination. I know that wasn't part of the study, but they didn't show it to me even anyway, with not being a part. So I really think it's going to be one versus the other. I sort of have my mental algorithm. If cost were not an option and insurance wasn't an option, how I choose which one clinically. But I'm not convinced that there's a role for combination.
All right. Very helpful. And the cost thing, it's also, I mean, you heard the discussion around the 20 milligram issue. That's, again, it's off-label, if you will, but cost being such an important or obvious element of this thinking here. Do you guys want to wade into that murky water around whether you would ever imagine using 20 milligrams? Maybe you already did. I forget if you commented on this, but David Wren did state that we know two relatively large health systems are using 20 milligrams as their preferred dosing. So what is your personal view of that? Should a payer want to contemplate combination therapy, is doing it with 20 milligrams? Is that like going way off the end of the diving board, you know, without any kind of evidence behind you, or is it something that you think clinically might make sense?
We don't have any data to say if you're going to give combination, give a 20. I remain agnostic. I just don't have enough information to comment. I'd love to hear Matt's perspective.
Yeah, I agree. I don't think there's any data. I do think that, you know, insurers are trying to do the best they can in a very difficult circumstance in which there are these are hugely costly outlays to them. And ironically, I think picking on the the group that's done that, particularly the VA Medical Center, I think is unjust, because they're trying to do the best they can with a fixed amount of money. And the problem really, in my opinion, lies with the cost of the drug, not with that. So I understand why patients do it. And parenthetically, tafamidis has a half-life of about 51 hours. So you could, you know, do all sorts of things and taking the drug a little less frequently to get around it. And people do that if they need to.
Okay, that's interesting. Yeah, I mean, it is, the VA is, I think it's publicly known that they are doing that. Somebody told, I mean, this drug accounts for a very large proportion of their drug spend as it is, even at 20 milligrams. But anyway, we'll have to see what future.
I'm told it's in the top 10 of drugs that the VA spends money on, despite it being a quote unquote rare disease.
Yeah. Okay, so let's move to step therapy then. Let's assume whether payers do or don't, include combination therapy. Let's assume for the time being that we're talking about monotherapy for a newly diagnosed patient. The panel voted unanimously that the evidence wasn't there to be able to distinguish between the three drugs as far as monotherapy. So again, Alyssa, from where you're looking, vutrisiran, unless they change the price, I mean, there are about 4,000 patients in the US I found have polyneuropathy, amyloid polyneuropathy. That's what Google said. I know we did our own review on this, and I could have looked back at that, but I quickly did it. Let's assume it's ultra rare, less than 10,000. Now it's going to get, let's assume it gets an approval for, cardiac amyloid. I don't know what they're going to do with the price. It'd be nice to have them here, but let's assume that it's still much more expensive than tafamidis. I mean, is the obvious the obvious? Do you think that payers will consider doing step therapy? I know that if they do, the first thing they'll ask of their clinical experts is, are there certain patients that need to be on one versus the other? We really need your opinion on whether there's a slice of this pie that has to start with a stabilizer or has to start with the silencer. Otherwise, we're going to go full body competition and see what the lowest cost one is and ask people to start that one first. So clinical experts, again, how do you think about that question?
So let's assume, okay, this is what I will do when vutrisiran is FDA approved, when acoramidis is FDA approved. Let's just take a fresh patient who's not on anything, or even someone who's on tafamidis. First, honestly, I'm going to see cost. I'm going to say, which is cheaper for you? Because honestly, I think they all work and I can't do a head-to-head. If one is cheaper, let's switch you to that. My next question is going to be, if cost then is not the next issue or not important to them, I'm going to say, how do you feel about an injection, subcutaneous injection every 3 months versus a pill every day? Does that seem to matter to you at all? And then maybe that'll factor into it. And then the third piece will be, do you have neuropathy? Because I do, in wild type or variant, even though the silencers are only approved for the variant because they're only studied in the variant, I'll say maybe we have more data and strength, so maybe I'll put you on that one. So it'll be cost, patient preference, presence of neuropathy that'll sway me to one versus the other. And again, as I said, I really don't understand a role for combination, so I will try my best in conversations with patients, even if insurance will pay for both, to try to make a middle ground for a single agent.
Okay. Matthew, how about you?
I completely agree with Michelle. I think at the end of the day, to be honest, I'm not going to get a choice of which one to prescribe if the cost is differential. And only if the cost is the same will I get a choice to then select which agent. And I hope competition leads to lower costs of the drugs. I would definitely lean toward a silencer in someone who had a neuropathy, as Michelle said, assuming cost is the same over a stabilizer.
Okay. John and Alyssa, you've just heard from two outstanding clinical experts to address that question. What does the insurance coverage policy look like?
First of all, thank you for this information. Both of you will probably be quoted at our P&T committee meeting. My gut feeling, as I hinted earlier, is to wait a little bit before considering step therapy, see how the evidence develops, see what happens, whether there is in fact any change in pricing. How long that will take, I don't know. Whether Premera will follow that advice, but I don't see, the situation doesn't look clear enough to me to jump in either way right now.
And even if the price differential is $300,000 a year?
As I say, that will definitely be a factor. And it will probably shorten the time before we face that decision.
Okay. Alyssa, what do you think? And by the way, we haven't talked really about any difference, if there is any, between the commercial insurance and the Medicare or Medicare Advantage or other, because a lot of these patients are obviously Medicare eligible. So feel free to comment on that too. But how do you view the likelihood of step therapy, the way that it'll be approached?
Yeah, just from a broader perspective, obviously we talk to a lot of payers. We do see variability, especially in rare diseases with step therapy, with the implementation of step therapy. There's a, particularly, some pause with rare disease where there is, and it was very enlightening hearing our clinical experts kind of think through their thought process, because that's how payers are thinking as well. Patient and provider preferences, are really important with these diseases, and it might not be appropriate to tell them they have to try something first when there are so many factors at play. Of course, I think it'll be very important for payers to be aware of the patients with the mixed phenotype and whether that's appropriate to require step therapy in those instances. But in the absence of that, if cost does, turn out to be roughly half that of a stabilizer, a silencer, if the cost of a silencer is double that of a stabilizer, then I do think we're going to see a lot of payers moving towards step therapy in the appropriate patient population, just given that cost discrepancy and the fact that diagnosis is increasing. It's becoming less rare to the point that a lot of people have made. It's nearing, the threshold where is it even a rare disease, and so some of those reservations over, let's let the doctor decide kind of go away the more prevalent the disease becomes. So I think we'll see variability, to summarize. And to your question regarding Medicare, I think that is going to be, important, because especially with the provisions of the IRA, Starting next year, patients getting drugs through Medicare Part D, it will be a lot more affordable. We're going to have that $2,000 patient out-of-pocket cap. We're going to have smoothing, which will allow them to pay a set amount, kind of divide that up. If they were responsible for that $2,000 up front with their first fill, they have this opportunity to spread that out over the year. And that will make the drug a lot more affordable. And with vutrisiran, that will be a provider administered drug. So we're going to have different dynamics there. So a lot
You
at
read
play.
you read my mind. I was going to ask about that influence both in the insurer's mind, but Sean and Milton, if you have a perspective on this, again, not just from would patients prefer to take a pill versus get an injection once every 3 months, but we talked earlier about equity. Is there, let's say we're doing step therapy and we would require a doctor's visit every 3 months to get the injection versus a pill you can take at home. I'm just wondering, and clinical experts, I'll circle back to you on this as well. Are there equity concerns here in terms of about ease of access or adherence between those two that payers should take into consideration when they're thinking about step therapy? Sean or Milton, what do you guys, if you've heard from patients in the community about how they view the difference between the pills versus an injection in the doctor's office?
I've not heard much talk about the difference between injection and pills, but I can tell you, particularly with patisiran and the evolution of vutrisiran, the fact that I only have to drive into Boston once every 3 months as opposed to once every 3 weeks, and looking at the trial results and how effective the medicine was, that was a very easy decision for me to make. It was
Thanks.
more convenient, I guess you'd say.
Yeah.
But as far as step therapy, I would always advocate for my own position that I want the best medicine possible, the scientifically best medicine possible, and it sounds to me, and pardon my ignorance on this subject, but step therapy sounds to me like it is, we'll try one thing and see if it works for a while, and if it doesn't, we'll move on to the next strength medicine. Is that an accurate statement?
Well, that's a big question. That's a big question to ask. I mean, part of what you've heard people wrestling with all day long is whether the evidence allows us to say that one is better than the other. And if not, and there is a big cost difference, if you were shopping for a car and they both had about the same miles per gallon and you like the color about the same and one was $10,000 cheaper, you'd probably say, why not?
True. I will tell you, when I was diagnosed and my doctor told me that I was going to start on patisiran, it had just, recently come out of trial. So I was skeptical about, side effects and whatnot. And I asked him, I said, what if I don't use this drug, what's my other option? And he was quite blunt with me and said, you'd probably be terminal in 2 years or so. So it was a no-brainer to start that, and it was a no-brainer that I wanted to be on that medicine. And given its robustness and its success in trials, that's the medicine that I want. I do not want, as a patient being told I might have 2 years to live, I don't have time to do step therapy. I don't have time to try one thing and see if it works. And if it doesn't work, we'll try something else. I want to go for the jugular, if you will, all at once. I don't know if that's the answer to your question, but
it's the way I would hope, honestly, that everybody feels. If there is a better choice for you, then that's what we would want to hopefully be able to get.
Yeah.
Milton, any other thoughts around this general idea of access to injections in a doctor's office versus pills, that kind of thing?
Yeah, I would just say definitely the issue that came about the traveling.
Mm-hmm.
Most people are looking at it once they start getting some sort of illness, particularly with amyloidosis. At least the ones I speak to, whether it's on Facebook or in person, it's always about, I don't have time for all this. which means they want the best medication. Yes, they do. But to actually drive here, go there, or that inconvenience of it all seems to be more of a turmoil, when they can't really focus on whether I should get the shot, which might be better for them because maybe they got to go in and out for a reason, versus the pill, which might be, a little more time consuming on a daily basis or whatever. But I think it's more or less about the where can they get it from, the travel that's involved. That's a wear and tear on a lot of the patients.
Got it. Now, Alyssa or John, do you guys have any hard knowledge of right now the difference in the of the application of the IRA to the out-of-pocket and also the catastrophic phase management of costs for payers between a Part D and a Part B drug at this stage? Do you have any insight into the relevance of that for a step therapy decision, for instance? My guess is that, well, I shouldn't guess. Let me ask you guys, do you have any thoughts on that at this point?
Well, the interesting thing here is that depending on exactly how it's operationalized at the payer is that the step therapy will cross benefits. So, you may be requiring a Part B drug, before access to, or a Part D drug before access to a Part B drug. So there's dynamics there. But largely, there's so much variability in patient out-of-pocket costs for Part B drugs, just depending if you have a Medicare Advantage plan, if you have traditional, what supplemental coverage you have. So it's really hard to, get a sense of how much patients are paying for a provider-administered therapies, unfortunately. But it does seem with the IRA that, these Part D drugs, oral drugs, will be a little bit more accessible financially.
John, any thoughts?
Yeah, definitely not an IRA expert, but this problem we've seen before. You can perversely create a situation where the patient pays a lot less for a more expensive drug. That is something that Medicare should deal with. Of course, they don't listen to me, so it is what it is.
Well, we may, when we get around to the CEPAC comments later, we do have at least one Part D redesign expert on the panel who may have some insights into this question that we might be able to glean at that point. Matt, go ahead. Maybe if you were addressing.
I just wanted to emphasize, I do think at least my patients, concordant with what we heard, are going to pick what is the best therapy. Adherence is very high no matter what therapy people get in this disease once they're diagnosed. I think that the other thing that will be interesting is there will be, God willing, if class of medicines all work, there'll be another silencer that is administered subcutaneously by the patients in their homes. That's going to be Part D versus Part B, and there'll be probably some interesting analyses that could be done in that particular regard. And to be honest, I tend to choose that in patients who are eligible now, who are frailer and can't come back and forth as easily, to be more patient-centered.
Actually, is there any clinical reason that patients need to receive this sub-Q in the doctor's office? Could they take it home?
Not at all, in my opinion. No, they could take it home. It's just how they've, put the drug out on the market, concordant with the infusion of patisiran, which was 17 times a year and required, expertise in monitoring. These drugs are subcutaneous, no pre-medicines, and can be administered anywhere.
Okay, well, that might be something. I'm sure that a lot of payers are going to be looking at that question, is if they can shift it over to Part D, it might both be more convenient for patients in certain ways, and it might change the price or the cost dynamics for payers, I'm sure. Sorry, Alyssa, go ahead.
Sorry, I heard it from our clinical experts, and I heard it, from our patients as well. And this is something that payers look at as well, is how do the therapies compare? So you both have said they want to be on the best drug, but as we talked about earlier, it's virtually impossible to say what drug is best. So, I don't know if there's any thoughts from the experts on that, on like exactly how you'll navigate it in the absence of a super patient specific, characteristic that might drive you towards one or the other, like a mixed phenotype. How will you navigate that? And, how should payers navigate that in the absence of data that tells you that one is obviously better?
Well, I think Michelle,
Yeah.
Michelle's three-step approach that Matthew agreed with is going to be highly quoted by a lot of people because it's brutally common sense. as I heard it as well. Michelle, do you want to restate it? Because it was very, very helpful.
Yeah, I think your point was well taken, though. Like, say, I think cost will drive it, number one. If all are equal, the offer to patients, if clinicians have an option of any three, acoramidis, vutrisiran, tafamidis, number one, cost, number two, patient preference for administration, and then, of course, the neuropathy. Those would be the three things. Now, if the patient tells me, I don't care, doc, you decide, that would be strange, but let's just say they say that, I would probably say, you know what, a pill's probably just better for the healthcare system at large. If the subcutaneous injection has to be administered in a hospital setting, that just adds cost to the universe that maybe we should try to avoid and just take a pill. Now, when we get to self-administered injections, then it becomes a little more tricky. But that would be maybe my fourth stage if the patient says, I get to pick.
I just want to foreshadow what I believe is going to happen. Again, cost may be the same. If it's not, that'll dictate, like Michelle said. But we're all in this field very patient-centered, and we're going to need to build systems that are even more complicated at the clinical sites than we have now. And those systems involve that we're doing at our site, phenotyping patients and figuring out who's progressing, right? Because when someone is on tafamidis and progresses, it's very hard as a clinician to look them in the eye and say, well, there's alternative therapies, but your insurer isn't paying for it, but I think they could be better. And to the point is acoramidis a better stabilizer? I'm sure people might be convinced of that now, or will be convinced, who knows whether true or not, and the same for others. So I fear at our center, we've built a program in which we do lots of phenotyping, 6-minute hall walk, short physical performance battery, quality of life questionnaires, looking at biomarkers and so forth. And I think we're going to need that information to advocate for our patients in order to get them a new drug if we think it's indicated, or a different drug, especially if they're not equally cheap or expensive.
Yeah.
Yeah.
Okay. We have, oh, I'm sorry. Somebody wanted to.
No, I was just going to say, you brought up one, I think this is important to the discussion, is, tafamidis progressors. If there is this step therapy, how can, how should payers view who is progressing on tafamidis? Should it be some of the walk distance? What do you look for with that? Because I think that will really help payers in deciding, because the step therapy is one thing, but how you operationalize it, how strict you want to be. Do you just let the doctor check the box that they're progressing, or do you want to see those markers in their chart notes?
One thing that troubles me about Matt runs the biggest amyloid program in the universe, and if I have amyloid, I want him to be my doctor. But what troubles me is, just because they're progressing on tafamidis, are they going to do better on vutrisiran? I don't know, and it makes me. I feel like you're injecting a bit of false hope then, or creating an algorithm of step therapy when no data is there to support the benefit of that algorithm. And it troubles me if anyone puts together a protocol for step therapy, because I just won't know what it's based on.
And I agree with Michelle. I mean, I think it's an unknown territory, but I think it can't help but believe, or at least hypothesize, that better phenotyping of patients and tracking. We're in this very confused space as clinicians. We don't know which one to use in what order, and I fear we're going to be marketed to up the wazoo, and that effort could be better spent in trying to sort these things out. If I had to do it over, we encourage the companies to try to do head-to-head trials and compare, and that would have been great. But there are obvious reasons why they chose not to do that. Part of which, to be honest, back to cost. You try to include an arm of tafamidis in your trial, that's $500 million to just buy the drug for the patients.
I know. We're going to actually I want to make sure we save at least maybe 10 minutes or so for discussion of future research, because that's a critical issue right there. The manufacturers opted not to participate in the policy roundtable, which always is a disappointment to me. I think they really, in a sense, our society grants them a privilege of getting, they do great work, they take great risks, but when we give them a patent and they come before us, it would be nice for them to participate in this kind of conversation so that we can help get it right for patients at all levels. And one of the things I would, in a sense, have asked them to reflect on, so I'll ask you as well, I've been in lots of rooms with investors and others who really want to turn their condition that they're focused on into oncology. multiple expensive drugs have to be used in combination for a long time. It's a great way to get a good return on investment. It's very, it's good for patients, of course, but it's also a very good financial opportunity. If you sit in a room full of insurers or employers and you say everything should become oncology, they turn white, right, as ghosts. They feel like if that happens, they're going to bleed the system dry. And here we are with a relatively common condition, even if, let's say it's 200,000-ish, 150 to 200,000 ultimately. If we stack very expensive drugs, especially those that are initially approved for very orphan conditions, and keep their price as they move into larger patient populations, it just, to me, it feels like we're straining the system in every which way, and patients are ultimately the ones who seem to bear the burden. Matthew, you've talked very eloquently in some of the previous commentaries with our CEPAC around the impact of financial toxicity. Is there anything other than just the general exhortation to keep prices lower and aligned with patient benefit that we can think of as a recommendation to the system that you can imagine that would help us get to a better place as this field does continue to progress with innovative new drugs?
It's a great question. I've been solely focused on the price of the drugs. Look, I think credit where credit is due. People have done miraculous things for this field, mainly mediated by the fact that we have disease-modifying therapy. And, I applaud them, but I just think the price is outlandish and needs to change. These drugs are available in other countries for, not permitted publicly to say, but, in the range that ICER believes the drug cost should be. And so I think it behooves our government to stand up and say, this is great, thank you, but there's some cost containment, I think, at the end of the day.
John, Michelle, Alyssa, others, anybody else want to chime in either with just condolences for the common challenge that everybody faces, or any ideas for ways to address it?
This is a very small idea. This is a tiny, tiny drop in the bucket. But the principle I think applies to healthcare at large is that I think as physicians, clinicians, we have to know when to deprescribe and when to not do stuff. And the ability to take things away could be hugely cost saving for the healthcare system. I think that if you deprescribe people from tafamidis, again, you're not going to help. You're not going to solve the problem, but I think as a principle in general, that's very important.
You guys are great representatives of your profession in many ways, I would say. But the other thing I might mention is a potentially small, but sometimes influential step is, if this area is going to start to feel more like oncology, the oncologists as a society did get out there and even created the term financial toxicity and popularized it and pushed it into their own educational systems to a certain degree. Not that they've solved the issues, but it feels like cardiology, neurology is in somewhat of a similar situation. They feel like they need to start talking more about this balance of costs and benefits in a way that can be helpful for their patients. So my hope is that cardiologists like you will help, kind of share that perspective, that we can have innovation and companies can do quite handsomely, but we need to figure out how all the pieces fit together. Sean or Milton or Matthew, if you want to come back, go ahead.
Yeah, I was going to say that, ironically, one thing I told the CEO of Pfizer at the time when we presented the ATTR data was cardiologists were not oncologists and that we'd have a cost sensitivity. I was, to be frank, totally incorrect. There was an interest in this field because we've made progress. The patients are lovely and all the other things, but there's a big interest in pharma because Pfizer's making in the US alone $6 billion a year. So, having said all that, I would argue, I'm not an oncologist, but these drugs really, really, when given early, prolong life by years, and to really revolutionize things. My colleagues in pharma always tell me they will one day go off patent and it'll be cheaper, and I'll be happy at that point in time, but I haven't seen it yet.
Okay.
Yeah,
Milton.
Can you hear me?
Yes.
Yeah, I just like to say, if you reduce the cost, which I hope they do, it will save lives. It will increase people's livelihoods. It would take a lot of stress off of the caregivers. And I think it'd be a great thing to do. I think this should be the American way to do that because those drugs really do help.
Thank you.
The one last crazy idea that I proposed related to access and so forth is it's very clear to me that where you live, unfortunately, in the United States predicts your income and your deprivation. And we know in the areas where people are making incomes that are well below the metrics that they're ever going to need to pay for this drug. And I personally think that the sponsors should do a better job at basically waiving all the paperwork for those individuals so they're not running around trying to access the drug very quickly. Whether insurers could help in that regard too, but it's very clear to me who the people are who have trouble accessing the drug, and it's not, again, because they have to pay for it. It's just because the process is too onerous, and that seems unethical.
Okay, thanks. No, I'm glad you came in with that as a specific idea. I like it. All right, I'm sensitive again. I want to make sure I give you guys ample time to make your final statements. Let's talk briefly about future research, and this is usually something that the clinical experts who are also researchers have a lot to say on. But I'd invite the people from the insurance perspective or patient experts to chime in as well. Matt, you mentioned head-to-head trials, right? As a specific need. It would have to take probably funding from a group like PCORI, who has big resources, and the companies don't have the kind of incentives, if you will, to try to do those kinds of huge studies. And you raised the important issue that anybody trying to do a study needs to get access to the drugs at a price that makes the research itself feasible, right? I mean, that's hard to accomplish, but it's something we can talk about. Let me start with the clinical experts. If you had to identify two specific clinical research needs that are the most high priority from your perspective over the next 5 years in this field, what would it be? And it's probably stuff you're already doing, but
No, not necessarily. So back to drug development, I make the following proposal, which was rejected by one of the companies. But since we wanted to know if one drug is better than another, and since Medicare bears the burden, I'm sure you're all aware of this, when we do device trials with LVADs or pacemakers, Medicare picks up the cost. So I would submit that since Medicare is paying for majority of these drugs, they should cover the cost of the quote unquote control arm, and then tell the company, we're going to get the best evidence we can, but because we gave you $500 million, which by the way, you're making every 2 months on one of these drugs, we're going to ask you to, for that, lower the price, and we'll help you in your development. So the government would encourage competition as opposed to what currently happens, which I think is there's no competition in the field in the development, and it's very complicated. The other thing you mentioned already, which is there'll be enough people on these drugs where someone could do a PCORI type analysis and try to really understand on a high level, outcomes of mortality and morbidity, hospitalizations, and maybe even some better phenotyping to find out which drug is maybe better, or are they all really equal.
All right, great, thanks. Michelle, anything you'd add?
Yeah, two things. One is earlier starting for those patients who have very finely curated insurance company requirements to take in. Their NT-proBNP isn't there, but they have a positive technetium scan. I think if there was some data so we could show it doesn't matter what your symptoms are, if you have evidence of cardiac involvement, you should be started on therapy. That would be very important. And number two, this whole step approach we're talking about, we need data to say that when you verse in a different therapy makes a difference.
That's great. Okay. Again, as I mentioned at the beginning, we've already talked for essentially an hour and a half, and I feel like we could go back through each of the issues we've talked about and do another hour and a half on them. You guys have provided tremendously valuable perspectives and specific ideas. Before I hand it back over to the CEPAC to have their final statements, as you guys know, we like to invite you to make a final statement, and it's usually framed as a request to make it a single sentence so that it really sticks with us. And it can either be a restatement of something that you've already heard or already said. It can be something that just didn't make it into the conversation that you want to make sure is heard before the end of the meeting. And I also like people to think of potentially making it framing it as a request. So if you had one thing to ask of one key stakeholder that they could do or do differently to make the world a better place, what would that be? So with that as my general guidance, I do want to let the patients have the last word. So Alyssa, why don't I start with you, and then we'll kind of run around the horn with everybody. Again, one sentence with a strategically placed semicolon. The young kids don't know what that is anymore. It's not something we old people used to use. It's called grammar, but that's all right. Anyway, go for it, Alyssa.
Yeah, I think it's something we didn't talk a lot about though. It's important, I think, for payers to recognize the value of earlier treatment and, not impose these unnecessary barriers that just pretty much delay the inevitable in accessing treatment.
All right, thank you. John?
Very unusually rich topic, I think. You've heard from the clinician experts. I would just add my encouragement to do that further research that we all want to see.
Okay, thank you. Michelle?
I'm going to say that the challenge really for the clinician caring for the patient remains having a high index of suspicion in the face of the clinical clues to order the right tests. And then the challenge for us as researchers is giving them the guidance when the landscape of therapies increases to figure out what's the algorithm that makes sense pathophysiologically, clinically, and economically.
Beautiful. You think in threes, don't you? I like it. Matthew?
Yeah, I echo Michelle's sentiment. I think early diagnosis is the key to really improve outcomes in patients, more widespread use of genetic testing. And I would question whether or not this disease actually meets the FDA's definition of being rare.
Okay, thanks. All right, Milton?
Yes, lower the cost of drugs and make them more accessible.
That's a sentence I can get behind. Sean?
Yeah, I'm going to expand on what Milton just said, and this, I guess this would be more specific, but earlier there was talk about how the Veterans Administration had to, one of their cost-saving techniques or whatnot was to only administer 20 milligrams of one of the drugs instead of 80. I think it's tragic that any veteran's health should be placed in further jeopardy due to economic reasons.
Okay, thank you. All right, folks, if you are able to stay for the last 30 minutes and hear the comments from the CEPAC, you will hear much praise for what they have learned from you and the contributions that you've made. But just know that from my perspective and that of the entire ICER staff, I really want to thank you for your contributions, not just today, but throughout the course of this report. And we know that your involvement will mean that the impact of the report has the imprint of people who are really expert in this area and have spent their lives either wrestling with it or trying to cure it and helping patients with it. So thank you very, very much. And let me hand it back over to Jill.
Okay, thank you. I guess if we can get the Midwest CEPAC members to come back on. We'll start with the reflections. I guess we'll start with Stuart.
I am pretty sure we have never been better served by our clinical experts today. They're clearly role models for all of us clinicians and an extraordinary value to their patients. As a cardiologist who had no tools to specifically treat this disease in the past, even when we diagnosed it by biopsy, it's extraordinarily gratifying that we have these drugs that have been developed. The price and the hoops through which the patients access the drug is frankly tragic.
Thank you. Rachel.
Sure. Of course, I want to join my panelists in thanking the ICER team and all the patient and clinical experts who've joined us. I'll pick up the invitation from Steve to say something about the Part D redesign. So my one sentence is the combination of the changes made by the Part D redesign, including the Medicare prescription payment plan, I think are going to transform the coverage incentives for plans and also access opportunities for patients in 2025 and beyond. And I'm looking forward to tracking those dynamics specifically for these therapies.
Kurt.
Thank you, Milton and Sean and all the panelists for doing a great job and helping me and helping us understand the consistent themes. And we've heard this a lot. We have effective drugs, they're priced too high, and we have patient access issues. And so look forward to solutions to those. So thank you.
Brad.
I kind of want to echo Milton's parting comment, about the price of these drugs. I mean, we look at the cost effectiveness models, we're so far away in the pricing structure. I mean, I think it points to, real realities. If we have more drugs coming on market in more therapeutic areas, where are we going to be able to sustain the system like we have right now? So it's, when you talk about potentially $20 billion a year, if you get everybody treated, maybe even more, these will just, I don't know if the system could absorb that.
Timothy. Timothy, we can't hear you.
Might have to come back to him if hopefully
we
he can
can-
figure it out.
You're good now. Speak.
No, that was me.
Nope, that was you. Sorry, I was reading his lips. We can't hear you, Timothy. We'll come back to you. Would that be all right? Okay, we'll come back to you. David Kim.
Yeah, on the top of all the panel says, I think we all do deeply care about the health equity, but we don't know much about it. So I think it's important to really push for the greater involvement among the underrepresented minority in the research trials.
Jayani?
Yeah, thanks again for the Quincy team as well as the clinicians and patient advocates. That was very informative. I think yes, I agree with Brad when it's concerned about the cost, and I also feel like what we have is this is progression slow treatment. We still need more research and development in terms of finding a treatment for this disease, and also underdiagnosis is a concern, but then worry about the high cost bill because the older adults want to be on this drug. Mostly, Medicare want to be able to cover all that if everybody's diagnosed and being on this. So I'll stop there. Thanks.
Heather.
Yes, of course. First, I want to thank ICER and all the clinical experts and, of course, the entire CEPAC panel. But most importantly, I want to thank the lived expertise subjects who joined us today, the patients. They are the most important component in any collaboration. And we are reminded that, yes, we have to strike a real balance for equitable healthcare policies that really kind of balance between clinical efficacy and economic feasibility, but we can never lose sight of centering the patient. And that would be my ask, that we not lose sight of that.
Inge.
Thanks for having me. This was a very fascinating discussion. Hitting $1 million per QALY from a societal perspective is mind-blowing. Hopefully with more drugs on the market now and maybe more coming, hopefully that increases competition and drives down prices. I'm a little skeptical about that. It happened with Hep C, I'm hopeful, but again, I think it's important to think about whether there could be thresholds where, as was mentioned, CMS can sort of force certain studies to be done to help us make better decisions. It's just not a good situation right now. Thank you.
Gregory.
Thank you very much. I'm sorry my video will not come on, but I hope you can at least hear me.
We can.
Okay. Lots of you have already talked about the high price of the drugs, and both Steve and Matt brought up the word patents. And so I'm going to suggest that this may be a situation where the concept of march-in rights and the application of march-in rights should be under serious consideration, where the government comes in, takes control of key patents, and is able to produce a drug or more than one drug at a much lower price. I don't know if Rachel Sachs could comment about the viability of the application of march-in rights in this situation.
Rachel, do you have a comment?
Well, I just think this goes back to Dr. Moore's comment earlier, which is that currently this is classified as an orphan disease. And so there's a 7-year period of market exclusivity. And so there's patents and there's also FDA exclusivity periods, and march-in rights or a statute, there's a separate statute called Section 1498 are relevant to patents, but it's not clear that they apply to FDA granted exclusivity period. So the orphan drug exclusivity period would be a relevant question separately.
Thank you. Aaron.
I want to reiterate a lot of the things that people said already about the excellence of the clinical experts and just thanking everyone for participating. I want to note that I think we really need to spend some time rethinking how we calculate a societal perspective, especially towards an elderly population, because seeing today's analysis, it strikes me that anyone over the age of 65, nothing will ever be cost effective, because making people live longer is going to cost more in terms of caregivers, going to cost more Medicare, is going to cost more Social Security. And if we take that tack, then nothing will be societally cost effective, even if it's free for someone over the age of 65. So I really think we need to take another look at that.
Thank you. Thank you for that. Bijan.
Yeah, again, I echo everyone saying or thanking the participants, particularly the clinical experts, as well as the patient representatives. So I'm gonna say like just 2 things about education. I think I really kind of appreciate what Milton said about educating the primary care workforce, because they are the first point of contact for the patients. And the negative part of education is what we know as direct to consumer education, or rather direct to consumer marketing. So I worry about that, because I think one of the issues that kind of came up was the sort of potential for misdiagnosis, because and that way I feel some of the drug makers might be kind of basically start having supply induced demand like through education or marketing. So that's something we need to be looking out for. Thank you again.
Eric.
I'll give a little gratitude to Jill, who navigated our voting session for the first time. So thank you for getting us through that so well. I really appreciate that. On the topic that we covered today, it was really wonderful to see a drug, even if it was very expensive, that had such a wonderful impact on quality of life. We often don't see, we often see gains in mortality, but not necessarily the gains in quality of life measurements like we saw here. So that was a bright spot in this particular case. I think my other takeaway today was, and I really wasn't, when I started studying this, I didn't quite realize this, but I'm kind of questioning, are we really dealing with a rare condition here? Or is this a condition that we thought was rare or seemed to be rare because our inability to diagnose it over the last 10, 20 years? We just didn't have the technology to do that. And so I just sort of, the whole framing of this particular condition was like as a rare disease or an orphan disease. And I'm like, maybe that's not what it is here. And it just sort of shakes my understanding of like the policy implications and the way we are approaching this. And I think even the questions related to equity. So that was one of my unexpected takeaways from today. And I would just really appreciate the clinical experts and I think even the lived experience of the patients that underscored the importance of the quality of life gains, and then maybe that we're not dealing with a rare disease here. I don't know, thank you, Jill, and everybody else for a wonderful conversation today, especially the policy roundtable. Awesome job.
Thank you, Eric. Let's go back to Timothy, see if you can, we can hear you.
Can you hear me now?
We sure can.
Oh my gosh. Okay, I got a new computer and new camera. So I mostly just wanted to echo Milton's comment, and I want to put it on my door. Lower costs, less accessible, make it more accessible. Sorry, I screwed it up. But I also want to thank the ICER staff and the patient experts. And that comment by Milton points to some real disparities. And I think we also need to focus in on that. And I think was also brought up by Eric's comment as well. So lower costs, more access. On my door now. Thank you, Milton.
Thank you all. I'll be the last one. I just really appreciate everybody tolerating my first stab today at the voting questions. I wanted to also say thank you to the patients for joining and for sharing your experience. Your shared insights are invaluable. I thought the experts, you experts are outstanding communicators. Thank you so much for your candor and your multifaceted, obvious understanding of health in the United States, not just coming from an expert's opinion, but from all the suffering that you're witnessing with navigating this. So I guess I truly appreciate your shared outrage at drug prices. Sometimes it feels like we're pointing at a lot of problems. I hope that an organization like ICER is able to put pressure where it causes a change. I don't know what the solution is. I guess none of us know what the solution is if they don't cave to everybody shouting from the rooftop that it is too expensive and it's gonna cause problems eventually with affording, everything else. So I appreciate your shared outrage with me, and thank you for a wonderful review today.
Thank you, Jill. I will have the last word so that I too can join Eric and everybody in thanking you. As Eric said, this was the first time we've had the CEPAC chair moderate the voting section. And I know personally how torturous that can be. I almost never escape fully intact, and you did great. And that's a testament to your diligence and also to the great work of the whole CEPAC. So thank you. ICER team, thank you. I will get a chance to also thank you offline, but what a great report. I've already noted my appreciation and admiration of our policy roundtable members. My own personal reflection kind of echoes a lot of what you guys have said. One thing is that I was really happy when we can hear patient perspectives from patient experts who have either personally experienced kind of, if you will, harder circumstances in our healthcare system, or who are really tapped in to a broad and diverse group of patients who are struggling with access and struggling with cost, not just cost, but everything about our healthcare system that is hard for people who come from minority communities, from underserved communities, rural, et cetera. That really enriches our ability to help the system get it right going forward. So I just want to, again, thank the patient experts today and note that that's especially helpful for all of us as we try to frame our recommendations going forward. And then the obvious, which is we tend to pick topics where we do see great innovation, right? Because that is in part where the new questions come, the new competitive questions, the new paradigms of care. And we have to kind of figure out the clinical aspects as well as insurance and everything else. But it almost always highlights this issue that even with the IRA, when we're now negotiating, we're trying to help with the patient out of pocket, which is a critical piece of this. And maybe for a growing number of drugs, we'll be negotiating prices towards the tail end of their career. But But this is a good example of as new drugs launch and we as a nation still don't have a systematic approach to moderating the price in alignment with the patient benefits, we create all kinds of problems. The VA is dealing with it in one way. Other insurance systems and health delivery systems will deal with it in other ways. And the silent, if you will, usually people who will suffer are going to be patients, especially those most vulnerable. And that just cannot be the system that we really want to highlight as the best in the world, when we could do better at moderating the costs and getting better access. So I do hope that the patient community and the clinical expert community, in addition to the payer community, can continue to bring some pressure to try to drive change. We obviously hope that evidence and public dialogue can be an important part of that. But I would love to see competition take its full measure of effect here. I want other companies to be incentivized to come into this space and to do more good work. But I am just concerned that we have a structural misfit that's going to lead to ever higher launch prices, and we need to continue to focus a fair amount of attention on that until we get a better system set up. In the meantime, again, this kind of public dialogue and the way that we can help through recommendations, support decision-making by payers, by patient groups and others is really important. So I just want to thank the CEPAC and for everybody who's listened today. And our last slide just highlights what the next steps will be, which include the final report coming out about a month from today. The whole meeting will be recorded and posted to our website next week. And as part of our final report, we take a month because we want to make sure that we try to capture the richness of this conversation as well as the votes, and produce a set of policy recommendations that can really get traction. So we look forward to sharing that with everybody by October 21st. And in the meantime, thank you again, and I hope you have a good weekend after today.
Thanks, everyone.